This is the Euthanasia presentation by Erica Christoph, Tara Olson, Doug Runde, and Kelly Wharton. The definition of euthanasia is the intentional killing by act or omission of a dependent human being for his or her alleged benefit. There are several different types of euthanasia, including voluntary, involuntary, non-voluntary, and assisted suicide. The most common ones that people think of when they are thinking about euthanasia are voluntary euthanasia and assisted suicide. Voluntary euthanasia is when the person who dies is the one that has requested to be killed or has done the actual act of killing themselves. And assisted suicide is when a doctor or another health professional helps someone take his or her own life. Sometimes it can be a family member in certain situations, but it's often called physician-assisted suicide, a term that became quite well known during the Jack Kevorkian time in the 90s. By action and omission. Euthanasia by action is intentionally causing the person's death by performing an action, such as giving a lethal injection. By omission, meaning that you're stopping life-sustaining treatments or you're using passive euthanasia, and life-sustaining treatments could include anything from TPN to dialysis to mechanical ventilation, CPR, IV fluids, antibiotics, chemotherapy, blood transfusions. Any of those can be considered a passive euthanasia form. Active euthanasia is when we actually use a lethal substance or medication in a lethal dose to end the patient's life. There are three main arguments for euthanasia. The first one is the compassion argument, or the die with dignity argument. The supporters of euthanasia firmly believe that allowing people to die with dignity is kinder than forcing them to continue their lives with suffering, especially in the instance of terminal illnesses. There was recently a very famous news article about a girl named Brittany Maynard, who at 29 with a terminal brain illness decided to go with this, and this was her main argument, is that she wanted to die with dignity. The second argument is autonomy. Every patient has the right to choose when and how they die. This is another main argument for supporters of euthanasia, and one that often goes together with the compassion argument when you're talking about it. The third one is public policy. Supporters believe that this can be safely regulated by government legislation, that it can be controlled, and that the instances of people who become out of control with it are going to be few and far between. Arguments against euthanasia are a little more extensive. The big one is that there are alternatives available, such as palliative care and hospices, both things that nurses are quite familiar with. I think we've all been in a situation where we've had a hospice patient or someone who is about to go to a hospice. The argument here is that we don't have to kill the patient to kill the symptoms. All the pain can be relieved. You're not worrying about overdosing with morphine or things like that, so you can give them the amount of pain medication that they are needing to control the pain and still be able to say goodbye to their family. This also allows families to be a part of the care without feeling like they have killed someone. There's also the slippery slope, which is giving the doctors the power to decide when a patient's life is not worth living. By acting on voluntary euthanasia, are we opening the door to involuntary euthanasia? In the Netherlands in the 1990s, around 1,000 patients were killed without their request. At this point, the doctor has been given the right to kill and to decide when a life is worth living. And so people are afraid that if we do open this door, that there's no closing it. There's also the argument saying that the patient's right to die becomes a doctor's duty to kill. In the Hippocratic Oath, it is stated that one of the first rules of doctors is that they are to do no harm. And according to the American Medical Association, in Opinion 2.211, physician-assisted suicide is not something that they agree with. It's fundamentally incompatible with the physician's role as a healer and would be difficult or impossible to control and would pose serious societal risks. Asking a doctor to violate this Hippocratic oath would be, again, going down that slippery slope. Where is euthanasia legal? It is legal in the following areas, and you can see them lit up on the maps. The Netherlands, Colombia. In India, only passive euthanasia is legal. Mexico, active euthanasia is illegal, but passive is also legal. Belgium, Luxembourg, both in Europe. And in the United States, Oregon, Vermont, and Washington have legalized physician-assisted suicide with legislation, and Montana has legal physician-assisted suicide via a court ruling. In the 3 states, Oregon, Vermont, and Washington, you must be 18 years of age or older, a resident of that particular state, and you must have an oral request to the physician, a 15-day waiting period, another oral request to the physician, another 15-day waiting period, and a written request. And then there has to be a 48-hour waiting period before picking up any prescribed medications, and you have to get them from a pharmacy. Ethical principles that are involved in this include the principle of autonomy, which we talked about a little bit earlier in the arguments for euthanasia. It's an agreement to respect another's right to self-determine a course of action, supportive independent decision-making. Or, said another way, that a competent person has the right to determine his or her own medical plan in any way he or she chooses, and that we as healthcare professionals need to respect the wishes and desires of a competent person. The principle of beneficence, compassion, taking positive action to help others, and these definitions come from the American Nurses Association. In another way, beneficence is that a person should act to further the welfare and benefits of another and prevent evil or harm to that person. It requires us as healthcare providers to do something for that person. Non-maleficence, it's an avoidance of harm or hurt. It's a way that a person should refrain from inflicting harm or accidentally risking the infliction of harm on another. And the principle of fidelity, the loyalty, fairness, truthfulness, advocacy, and dedication to our patients. It's an agreement to keep our promises, and it refers to the concept of keeping a commitment and based upon the virtue of caring. When looking at the ethical principles listed above, you can see how they can all be violated when talking about euthanasia. Sometimes the principles overlap and intertwine so that as you are honoring one, you are violating another. An example would be a patient on dialysis wants to stop treatment and let nature run its course. The patient is competent to make decisions. This example shows a conflict between the principle of autonomy, a competent patient choosing not to continue medical care, and those of beneficence and non-maleficence, the avoiding of harm or hurt by us as healthcare providers. Are these principles violated? We are violating autonomy every time we say that a competent person has the right to make their own decisions, but then doesn't let them do it because of state law. The best example of this is the recent news about Brittany Maynard. She and her family chose to move out of California, where euthanasia is illegal, to Oregon, where they have a death with dignity law, and she did choose to end her life that way. Beneficence, it's violated by the act of euthanasia. It's not normally considered a positive action or doing good. We're supposed to be able to advocate for our patients and help them control their severe pain and help them die with dignity, but it goes against everything that we're taught as healthcare providers and what we're supposed to do. Are these two principles violated? Non-maleficence, it's violated by the simple act of euthanasia. We take an oath when we become nurses that we aren't going to do harm. that we are going to ensure that they are cared for to the best of our ability and that they are going to be comfortable to the best of our ability. And that's a very open for debate question, especially when you are talking about how people are allowed to die. Fidelity in itself is violated by the act of euthanasia. You can't be loyal, fair, truthful, an advocate, and dedicated to our patients and keep all the promises as healthcare providers. It's one of those things that I think we've been talking about a lot in this class, especially when you talk about how our own ethics and personal views are going to be challenged. And this is definitely one of those issues. Potential outcomes. Allowing a person to die with dignity and letting them choose their own death helps the patient who is dying from an irreversible, overwhelming, suffering disease and towards the very end of their life. The idea is not that a person is committing suicide, but they are hastening the inevitable. A great example that we've been mentioning for this topic is Brittany Maynard. She was 29 years old, she had months to live, and she wanted to end her life in a way that she felt was dignified. There are only 3 states in which there are death with dignity laws. Other states have had to come up with alternatives for patients. Some of the other options are accelerating opioids for pain or dyspnea, stopping or not starting potentially life-sustaining therapy. We talked about dialysis and ventilators, IV fluids and TPN therapies, which would fall under voluntarily stopping eating or drinking and or palliative sedation. And in an article that we found, we had a quote stating, "Excellent palliative care should be the standard of care for all dying patients, and no patient should be medically assisted with a hastened death because he or she is not receiving the standard of care. Palliative care, if applied with skill and expertise, can address most but not all end-of-life suffering. So the first place to go if a person is requesting assistance in dying is to make sure he or she is getting the best possible palliative care." The healthcare system has a moral compass that is and has been turning in circles related to this topic. As a nurse, we can see the benefit of having death with dignity laws, but also understand the dilemmas this creates. How can a healthcare provider assist a patient to their death? How can that person look that family of the patient in the eye? Many times it is not the patient, but the family that makes it difficult to help a patient make the best choice possible. I think we've all seen situations either in nursing school or in our own jobs where this has become an issue, especially when you talk about power of attorney, things like that, when you have family members who are arguing against what a patient truly wants. If a patient wants to stop chemotherapy and the family wants them to continue fighting, or vice versa, those decisions can become very much a conflict of interest, especially for healthcare providers. We are trying to advocate for our patient, and we may or not always agree with the decisions that they make. Another potential outcome, and one that is often used as arguments for or against, is the financial burden. What is more cost effective? Obviously, giving a patient a prescription to take a few pills and be done with life, in a sense, or prolonging the inevitable by any means possible. Have we sometimes kept people alive for the wrong reasons? Healthcare is extremely expensive these days. A one-day stay on a mechanical ventilation in an intensive care unit averages roughly $10,794 per day. With the insurance things the way they are today, that's something that not everyone is going to be able to afford, and you start wondering what's going to happen in regards to those Death with Dignity acts and the cost of the healthcare system. Along with the obvious financial burden of extended care for the terminally ill patient, there's also the psychological cost to the healthcare providers, the patient, and the patient's family. Healthcare providers pride themselves on helping others. It's why we chose to go into this profession. When they are not allowed to do this to the best of their ability and in accordance with the various oaths that are taken, it's difficult to cope with. Asking a doctor to completely disavow the Hippocratic Oath and mantra of do no harm can be extremely psychologically damaging. Most healthcare providers care immensely about their patients. They've come to know them, they've come to know their family members, and would have a very hard time in letting a patient do this. The patient may think they are mentally ready to die, but it would be very hard to swallow those pills knowing it will be the last time you see your loved ones. The family may also have the hardest time with this. They're the ones left behind to carry the burden, explain what happens, why the patient chose to do what they did. Not only that, but you are going to have to be sitting there for many patients. Family members will sit there and watch them take the pills. And that must be an incredibly hard thing to do. Again, with Brittany Maynard wondering how her mother felt when she was watching her take those pills, I'm sure was quite the dilemma for her and her husband and her family. All in all, no matter what decision is made, there's a high price to pay when it comes to this particular topic. So how will nursing practice be impacted by this development by 2020 if it is allowed to proceed? The nurse's role in euthanasia consists of registering a request for euthanasia. Many times nurses are one of the first medical providers to be presented with a request for euthanasia from a patient. It is the nurse's duty to assess its validity and take it seriously. A nurse's attitude can greatly affect whether or not a patient pursues euthanasia. We are also going to be the ones that ultimately could be taking this to the physician and letting them know that this is what the patient has requested of us. We could possibly be participating in the decision-making process. We would be participating in discussions and consultations with doctors occasionally, depending on the care team that is in place. And not only that, but in discussions and questions that the patients might have and the patient's family. Participation in euthanasia administration, that may vary between simply being present, providing supportive care, and actually administering the medication. Aftercare. Frequently, this step of the process includes only supportive care of the family and the friends of the deceased, and often includes an interview between the medical providers and the family of the deceased, giving them a chance to discuss their feelings and air any grievances that they may have. How will nursing practice be impacted professionally? Euthanasia goes against the profession. According to the American Nurses Association, nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations. Participating in euthanasia requires nurses to act against the requirements of healing, to act against that definition from the American Nurses Association. The goal is to heal the patient by extinguishing pain itself and not the patient who suffers the pain. Also, we could lose public trust. Nurses are viewed as caring, healing, and nurturing by society. By participating in euthanasia and helping to choose whose lives we end, we could lose the credibility and trust given to us by the public. In a Gallup poll in 2013, nurses were ranked as the most trustworthy. With 82% of American rankings, their honesty and ethical standards is high or very high. And we've been continuously listed at the top of the survey, beating out doctors, teachers, and pharmacists. Since 2005, over 80% of Americans have listed nursing as the most trustworthy profession. And that's a lot to undertake. Nurse autonomy could be compromised if euthanasia is made legal. Nurses may not have a choice in whether or not they are forced to participate in the administration of euthanasia. If this becomes a nationwide thing, if it becomes a standard of care, for those of us who are against it, who truly don't believe in any part of this, how are we going to be able to do our jobs effectively? How are we going to be able to care for a patient knowing that they're going to choose this and then being told by policy and procedure that we are going to be the ones administering that medication? The ethical aspects of euthanasia can have a profound impact on healthcare professionals and can give rise to deep, complicated feelings, questions, and doubts. Emotional support is thoroughly essential to this. We may frequently experience unease, which accompanies a sense of what is morally wrong with killing one's patients. We may struggle with wanting to uphold the ethical principle of autonomy, yet wanting to adhere to the core healing principles that nursing care is based upon, especially if this becomes policy and procedure and standards in hospitals and different parts of healthcare. These are our references. And we thank you for taking the time to sit and listen to our presentation.